Thyroid conditions can affect fertility. So if you have overt hypothyroidism or hyperthyroidism, this can mean that you have menstrual irregularities. This can mean that your periods might be heavier than usual, or they might be absent, and this of course then will affect your chances of conceiving. So the most important thing to do is to ensure you are euthyroid, and this should allow your periods to return to normal and improve your chances of conceiving back to your baseline. There is evidence that patients with subclinical hypothyroidism, where the TSH level is above the upper limit of the reference range, do have an increased risk of miscarriage. And for this reason, if you're planning a pregnancy, it's really important that we normalise your thyroid function before you try to conceive. So can thyroid conditions affect fertility in men? So this is a less well understood area of the literature, and it has received less attention than fertility in women with thyroid conditions. But we know that men with overt hypothyroidism or hyperthyroidism do have a potential impact on their sperm parameters, and this can then lead to reduced chances of conceiving a pregnancy with their partner. If your thyroid condition is treated, sperm parameters should return to normal and your chances of conceiving should return to your baseline. When we talk about sperm parameters, we mean a number of different things, but typically sperm motility. But ensuring you have normal thyroid function is the best way to reduce your chances of encountering any problems and helping to conceive normally. The recommendation is that all patients with a thyroid condition do receive hospital care during their pregnancy. So this might be done in what we would term a secondary or a tertiary hospital unit near you. So your midwife will be in charge of your overall care, but then your thyroid health and pregnancy should be managed by an endocrinologist as part of a joint antenatal endocrine clinic in a local centre. This will mean you can have regular monitoring of your thyroid function tests during pregnancy. The guidance on this depends on the underlying thyroid problem, but most women will have thyroid function test monitoring in the region of every 4 to 6 weeks throughout the pregnancy. For women who don't have a diagnosed thyroid hormone condition, but who are perhaps experiencing symptoms such as fatigue, it is, if there's a clinically relevant presentation, absolutely appropriate to check thyroid function tests during pregnancy. Women are not routinely screened, although this is a subject of much debate, but if there's a symptom that can be attributed to a thyroid condition, it's appropriate to check thyroid function and ensure it's normal. This is particularly important in women with other endocrine conditions, such as type 1 diabetes, where there's an increased risk of other autoimmune conditions. In an ideal world, we will know that you're planning a pregnancy. We can aim for definitive treatment pre-pregnancy, but if not, it would be really good to ensure you have normal thyroid function tests and normal thyroid hormone levels before you're pregnant. If not, it's important to let us know as soon as you find out you're pregnant so we can check your thyroid function tests and ensure you have joined up antenatal endocrine care during your pregnancy. This will mean we can keep you euthyroid. We can also counsel you about anti-thyroid drugs in pregnancy, propylthiouracil and carbimazole, and what to do with those. We can ensure adequate monitoring for you and your baby during the pregnancy. The most important way to prepare for a pregnancy is to get ready in advance. So if you have a pre-existing thyroid condition, it is really important to try and ensure that you're euthyroid at the point of conception, and this makes it much smoother for the rest of the pregnancy. You will reduce your risk of miscarriage and increase your chances of having an uncomplicated pregnancy. We do meet a number of women with hyperthyroidism in pregnancy, and this is usually Graves' disease, autoimmune hyperthyroidism. This does require enhanced monitoring in pregnancy. First of all, we need to ensure that the woman has normal thyroid hormone levels throughout pregnancy. To achieve this, they may need to take an antithyroid drug during some or all of their pregnancy, and I'll discuss that more in a moment. And the third thing we need to think about is thyroid receptor antibodies. There is transplacental passage of these TRAbs, and therefore, because they can reach baby and potentially impact on baby's thyroid, we need to check at the start of a woman's pregnancy if they have thyroid receptor antibodies, and then again, usually around the end of the second trimester, about 28 weeks in pregnancy. It's important to check for these antibodies even if your diagnosis of Graves' disease is historical and you've had definitive treatment with radioiodine or surgery. If we look at antithyroid drugs in pregnancy, women will either be taking carbimazole or propylthiouracil, PTU. Sometimes women will be on these treatments before they come to us. And the guidance is quite clear that if you are planning a pregnancy, or if you've just discovered you're pregnant and you need antithyroid drugs, PTU is the better choice. And this is because of the potential impact of these antithyroid drugs on the developing baby. So in the first trimester of pregnancy, PTU is the drug we should use. Although PTU can potentially cause some problems in baby, these are not life-limiting or significant problems which would have any impact on the baby's longer-term development and health. In contrast, carbimazole is associated with a more serious profile of congenital anomalies, and it's particularly important that we ensure developing babies are not exposed to carbimazole during the first and early second trimester of pregnancy. Once we get to 12 to 16 weeks of pregnancy, and there will be some variation region to region, we do recommend that women on PTU through the first trimester then switch to carbimazole. And this is because of the rare but serious side effect of liver problems for mums taking PTU. Serious liver problems are extremely rare, less than 1 in 10,000 women are affected, but because of the severity of the potential problem in the liver, women should be switched to carbimazole during the second trimester. Dose minimization in pregnancy is key, and the obstetricians will often work with us to ensure that the woman is only receiving the lowest dose of antithyroid drug that they require. The antithyroid drug can cross the placenta and concentrate in baby, so it's important that dose minimization is maintained until the end of pregnancy, and where possible we stop antithyroid drugs before the end of pregnancy. Women who are on levothyroxine for hypothyroidism often want to know what to do when they have a positive pregnancy test. Ensuring you have normal thyroid function tests before you conceive is the best place to be. But once you do have a positive pregnancy test, you will need to increase your levothyroxine to meet your requirements and baby's requirements. The amount you need to increase by will vary in individuals depending on your weight and other factors such as your thyroid function tests, but usually you will need an increase in your daily dose of 25 or 50 micrograms. Your target TSH in pregnancy is the lower half of the reference range, usually less than 2.5 milliunits per litre, and that's widely accepted in all units around this country. It's really important to inform the team looking after you that you have treated hypothyroidism so you can have adequate monitoring and care during your pregnancy. Subclinical hypothyroidism is whenever your TSH level is above the upper limit of the laboratory reference range, but your free thyroid hormones are normal. We know that patients with a TSH above the upper limit of the reference range do have an increased risk of miscarriage. And for this reason, if you're planning a pregnancy, it is sensible to take levothyroxine treatment ahead of trying for this pregnancy and throughout pregnancy. Once patients are on levothyroxine, we should treat patients to a TSH in the lower half of the reference range, so a TSH level of less than 2.5 milliunits per litre. Women often come and ask the question, if they have thyroid autoimmunity, but they're euthyroid, do they need treatment with levothyroxine during pregnancy? This is an area that has received a huge amount of attention in terms of research. We know that women that have unexplained fertility, those women do have a higher prevalence of thyroid antibodies. So there is evidence of thyroid autoimmunity there. But despite the large volume of research, we haven't been able to demonstrate a true causative link between evidence of thyroid autoimmunity and infertility of unexplained cause. However, it's very reasonable that women want to know if they have evidence of thyroid autoimmunity, should they take levothyroxine treatment. If you're not already on levothyroxine treatment, we are aiming for a normal set of thyroid function tests before pregnancy if you have thyroid antibodies. There is insufficient evidence to say that in women who are euthyroid and not on levothyroxine, that we should optimise their TSH to the lower half of the reference range, or less than 2.5 millunits per litre. If your thyroid function is within the standard lab reference range at the outset of pregnancy, that is where you should stay. I often discuss a key study with women, and this is the tablet study from around 5 years ago. So this was a randomised control trial, a very good quality study, looking at a large group of women, almost 1,000 women. And these were women with a history of infertility or miscarriages. They had evidence of thyroid autoimmunity, and the study was designed to find out whether treating them with levothyroxine improved pregnancy outcomes. And the key finding was that if you have thyroid autoimmunity, but you are euthyroid, treating with levothyroxine does not improve your pregnancy outcomes. The primary outcome in the study was live birth rate at 34 weeks, so towards the end of the third trimester. There was no increase in this live birth rate in women taking levothyroxine, even when they had evidence of thyroid autoimmunity. And for this reason, I reassure women that thyroid autoantibodies are common. Many of them, whether or not they have encountered fertility problems, will have presence of these antibodies. And while it warrants a check of thyroid function test to ensure that you're euthyroid, it does not mean that you need treatment with levothyroxine or that your TSH should be optimised to the lower half of the reference range. That target is for women who are already on treatment with levothyroxine. Levothyroxine is absolutely safe in pregnancy, and for the first trimester of your pregnancy, the developing baby is not producing their own thyroid hormone. So if you need thyroxine, your baby will rely on the levothyroxine that you're taking, but it's absolutely safe hormone replacement throughout pregnancy. It does require monitoring to ensure that you and baby are getting the right amount, but it can be safely used. Patients with overt hypothyroidism or uncontrolled hyperthyroidism in pregnancy are at risk of increased pregnancy complications. Now, it's difficult to quantify the risk in any individual, but we know that patients with abnormal thyroid hormone levels are at increased risk of miscarriage, later pregnancy loss, and complications for both mum and the developing baby. For the mum, there is an increased risk of blood pressure problems, usually hypertension, and in a smaller proportion of patients, preeclampsia. This itself can lead to other complications such as preterm delivery and the delivery of small babies. In terms of the baby's development, having abnormal levels of thyroid hormone can lead to changes in baby's growth trajectory as the pregnancy progresses, and this can mean your baby might be born at a smaller weight than they would otherwise have been. If you do have abnormal levels of thyroid hormone during pregnancy, it is important that you have enhanced monitoring, and you will need growth scans at 28, 32 and 36 weeks of pregnancy. The schedule might vary slightly depending on where you receive your care. There is regional variation, but growth scans are essential if you've had abnormal thyroid hormone levels during pregnancy. Sometimes women with a thyroid condition are concerned about their baby developing a thyroid condition. We know that thyroid conditions are more common in women because they're usually autoimmune conditions, but they're not single gene inherited conditions. And for this reason, I reassure women that the vast majority of babies are not born with a thyroid problem. But if you have a family history of autoimmune conditions, and thyroid conditions are one of the most common autoimmune conditions, your baby is likely to have inherited a pattern of genes that mean they too, as they progress through life, are at some increased risk of developing an autoimmune condition. If you have received antithyroid drugs for Graves' disease during pregnancy, or if your thyroid hormone levels have been abnormal during pregnancy, we can check thyroid function tests when baby is delivered. We do this on blood from the cord, so it doesn't involve baby themselves having a blood test. Some women with hypothyroidism don't feel well on levothyroxine, even when their thyroid function tests are normal. And this is a problem that is not isolated to pregnancy. So in our much larger cohort of women and patients who are not pregnant, we know there are patients who have normal thyroid function tests and take levothyroxine regularly but do not feel well. There are some additional considerations in pregnancy. So we know, and the evidence supports this, that we should optimise your TSH level to the lower half of the reference range. This is to give you the best outcomes in pregnancy, as well as to keep you feeling as well as possible during pregnancy. There are lots of other reasons for not feeling well in pregnancy. But if you already have an autoimmune thyroid condition, it's important that we consider whether or not you could have developed another autoimmune condition. And then there are other parts of pregnancy that are common, such as anemia and iron deficiency, that have nothing to do with your thyroid condition, but it's important this is screened for either with your community midwife or with the antenatal and endocrine team looking after your care. Breastfeeding is safe in women who need to take antithyroid drugs. The key here is dose minimization of carbimazole or propylthiouracil. And what we tend to recommend is that women split the doses across the day. Of course, with the shorter acting drug PTU, this is given in divided doses across the day anyway, but women should take a dose after they complete feeding, which usually means there's a gap before the next feed and reduced absorption of that drug by baby. With carbimazole, which we usually give in a single dose daily, it can be split and the dose can be taken across the day in two separate doses. But again, take your tablet after you've finished feeding, and then there's some time usually before you need to feed again. Both drugs do pass in tiny amounts into breast milk, but if you're on a low dose, your baby doesn't need any dedicated monitoring and we don't envisage any problems. It is really important to take the treatment if you need it, because if you have uncontrolled hyperthyroidism, this can lead to lactation problems and real challenges with breastfeeding. So we absolutely support feeding and take the medication if you need it, and talk to your team about your concerns. Often women will ask us if they're at an increased risk of developing thyroid problems after having a baby, and the answer is yes. We know when we look at the incidence of Graves' disease that there is an increase in this after women deliver a baby, and this tends to happen in the months after delivery, and this is because of physiological changes in the immune system that occur during and after pregnancy. So if you have a tendency to develop an autoimmune condition, you are at increased risk of developing it in the months after having a baby. Thyroid hormone fluctuations can cause non-specific symptoms, and often the symptoms women experience with uncontrolled thyroid hormone levels might be similar to that experienced by the mum of any new baby, feeling tired, irritable, more emotional, mood changes, anxiety, some other physical symptoms, fatigue. But if you're unsure whether or not you could have a thyroid problem, it's important to visit your doctor or let your endocrine team know if you do have an existing team, and that should mean you can have a prompt check of your thyroid function tests. Postpartum thyroiditis is a common condition that affects many women. How it plays out in each individual woman can be variable, but you will need short-term follow-up with the endocrine team. Some women will need to take levothyroxine for some time, and some won't. There is often a hyperthyroid phase when you have excess thyroid hormones, and if you have symptoms as a result of this, you can take beta blockers for a short time. Any of the medication you need to manage postpartum thyroiditis is safe if you're breastfeeding your baby. Many women who experience this condition don't need any treatment, but they do need monitoring. It's important to know if you have an autoimmune condition, you're at increased risk of developing postpartum thyroiditis. So if you have positive thyroid antibodies, type 1 diabetes, previous thyroid condition, you are more likely to develop this in the months after you have your baby, particularly around month 3 to 4 after delivery. There isn't routine screening, but it is wise that you get your bloods checked if you're concerned you're developing new symptoms.